This recording is going to be used to go through a chapter in Melnick. And this chapter is really dedicated to different models of evidence-based practice. So we're going to spend quite a bit of time, probably an hour, maybe an hour, a little over an hour, on different types of models of evidence-based practice, because you're going to choose a individual model and you're going to really morph your EBP project, your DMP project, around that model. So this model is going to be used to perhaps provide tools for you to use. It can provide a philosophical approach. It can help you to identify outcomes, perhaps potentially, and what type of measurement is going to be done. And it can really inform your approach and help you to organize as you move forward with all of this work. We know that there are always objectives. So I have only two objectives, but they're pretty broad when we look at different types of objectives. So the first thing I'm going to ask you to do is to be able to compare and contrast the bigger parts of these individual EBP models. With the goal that if you're able to get into this and really look at them, I think pretty quickly you'll be able to identify models that you think will be helpful and models perhaps that are a little bit out there. The goal of this again is for you to choose one as you move forward with your DMP project, and then that is what you're going to use to really organize the entire project. So Melnick begins this chapter with kind of an overview to EBP. We know that when you think about starting an EBP project, that there are literally hundreds of thousands of different questions that you can just drive yourself crazy with coming up with a question or only having one question. And we know that you can do an EBP project and find, if you will, you can change practice, and many times, as with even research studies, the more you know, the more you think you don't know, and there's more questions. We also know that these evidence-based practice projects have a lot of moving parts, and the goal again of this model is to make sure that it really helps you to organize those different parts. So this evidence-based practice started with Dr. David Sackett. And Dr. Sackett was a physician that was from Canada. And this gentleman came up with this brilliant idea in 1996 of making sure that medicine has its foundation or its basis in evidence. So he coined the term evidence-based medicine, which has really driven our evidence-based practice when we look at how it has kind of trickled down into nursing. Now, Dr. Sackett is no longer alive. He passed away at the age of 80 in 2015, but he was pretty prolific with writing about evidence-based medicine and did extend it over into nursing. So this is something that the mantle has been taken up by a variety of authors, and these authors have created these models that help to guide the implementation of evidence-based practice. Now, Melnick kind of globally defines evidence-based practice, kind of the different pieces to evidence-based practice, with it beginning with a spirit of inquiry, always looking around and really trying to make things better and ask those questions. So what is it? Why am I doing this? Why, where is the evidence to support that? That may drive that PICO question. And we've spent a fair amount of time with that PICO question, making it perhaps tighter depending on the literature you find, or kind of loosening it up. PICO question has multiple components that are in it, and it really frames this whole project that you're going to do. So you have your PICO question, you've got a good idea of what you want to do. The next piece is to go to the literature and find out if there is support. Now we know that you may find 10,000 articles, you may only find 2, and then you need to go back to your PICO question and refine it perhaps. But when you found that evidence, what you need to do is a real tight appraisal. To see the quality of that evidence, whether that is high quality or maybe a lesser quality, what the level of that evidence is based on the different types of research design. And you do that with a good appraisal. Once you've appraised that evidence, you have a good handle on what's there and what the results are and how much confidence you have in that evidence. The goal is to integrate it, to synthesize that evidence, and to pull those individual parts out of it. Very important is to keep your own experience right on your shoulder. So to be looking at things kind of critically, using that critical thinking based on your experience. And it's very, very important to look at patient preferences, your preferences, organizational preferences for change. Once you have developed this project and put it into place, hopefully there was baseline data and now you've done your project and you're looking at whether or not the change was effective. In order to do that, you need to have some means of evaluating it. And then we know that the final piece to this is to disseminate, to get that word out so that other people can use the work that you've done and really act on it. We know that there are different components to these decisions that are made as you move forward with this evidence-based practice decision, or this project. We know that originally the evidence-based practice started out as research utilization, and it is kind of the core of it, but we know that it's much bigger than just the utilization of research. We know that there's both internal and external evidence. I think Melnick does a beautiful discussion of that in your textbook. Internal evidence is that evidence that you have kind of locally. It's that evidence that is found within the system. Perhaps it's performance improvement evidence. Perhaps it's individual measurements that have been done within the institution itself, perhaps like infection rates or whatever. It's that information that you already have kind of internal to the change. And then we have external evidence, and that really would be that evidence that informs the change. Research obviously is a big piece of that, but it's not all based on research. There are other forms of evidence that can be used from an external perspective. So when we have EBP change, there's three important components, and these three I have a colleague that talked about a three-legged stool, that you really can't sit on that stool. If you don't have one of the three legs, you're going to fall over. So all three of these are really important. Obviously, the research evidence is tremendously important. That really informs the change. But so are the resources that are available from the healthcare perspective. Remember that depending on the type of change you do, you're going to utilize resources. And it goes beyond just cha-ching. However, it can impact that costs. It could be that you're asking nurses to do an additional assessment that's going to take time, or whatever those individual pieces are. So there's lots of different types of resources. We know too that patients' preferences are tremendously important, and it's patient and family. You would not want to do an EBP project that assumed that all mothers, for example, of newborns are going to bottle feed. You're not talking to the patient and making sure that there's not a different preference perhaps to breastfeed. So all three of these different legs on this stool are tremendously important, and they kind of all feed into each other. We know that there are characteristics from a clinical perspective that become really important, something that you're going to need to consider, as well as your own expertise, and we've talked about that. It's also tremendously important to look at the organizational structure and to make sure that the problem that you've identified is a priority or something that the organization will support this work. It's very important to identify early stakeholders and individuals who are change agents. So a stakeholder is anybody that kind of has a piece of this pie. And it could be that a patient and a family is actually a stakeholder, or it could be different individuals that are part of your EBP team. When we talk about change agents, there are people that are able to motivate change. So change agents may be someone in the administration. It might be an advanced practice nurse. It might be an individual staff nurse that seeks out, if you will, support and is able to be a pretty significant change agent. It begins with when we talk about organizational kinds of change, if you will. The empirical support is tremendously important. You couldn't do a big EBP change if there isn't some support from a research or empirical basis. We know that communication is key in everything, and good ongoing communication with team members and stakeholders and involved individuals is tremendously important. Being able to do a good evaluation is important. So when you consider different types of outcomes, make sure that you're thinking that evaluation strategy. And then finally, you don't want to go through all this work and have it not be sustainable. So sustainability is extremely important as well. So what I'm going to do really quickly is talk through the JBI piece. This is a circle, if you will, that you don't necessarily enter and exit or at any one place, but this is the perspective of Joanna Briggs, and I just think it's a good kind of global perspective. I have to put this into presentation mode so that you can see these individual parts. So the core of what it is that JBI believes in, the core is literally that fame scale, where you're leveling evidence and you're making sure that you have the best evidence, the most current evidence at any one time. And that evidence has these characteristics. Again, feasibility, appropriateness, and meaningfulness tend to be more from a qualitative perspective, as JVI has defined it, and that effectiveness is that cause and effect, and that is really a quantitative question. So we have to start somewhere. I'm starting at the top, and the top, this for me is really kind of an area I think that's a good place to begin, and that is JBI is a global organization. So if you're thinking about this as a method of evidence-based practice, remember that it's a global, it's not just something that is from the United States. Important that this global piece is sustainable and that the impact can be found everywhere. So you don't want to go through all this project from a JBI piece and not have it be able to be disseminated into areas where it could be utilized there. Very important is the provision for knowledge, and to have educational programming, and to have people that are engaged and ready to assist. If we continue in this circle down the one side is the generation of new evidence. That's the real foundation for this. If you don't have that evidence, you really can't move forward. It requires expertise and a lot of discourse. If we continue around, it's important to synthesize that evidence. Another major piece to Joanna Briggs is that it houses a database of systematic reviews. Again, those systematic reviews are a mega literature search, if you will, where an individual asks a question and then goes to the literature and finds the articles that deal with that question, very critically appraises them, and literally synthesizes the information, pulls it all together, and comes up with hopefully what would be a level 1 document that could be moved right into a guideline, a clinical practice guideline. We know also Joanna Briggs is devoted to taking those individual systematic reviews and producing evidence kind of packages that can be utilized by nurses at the clinical unit or patients if it is an education need or a technology need. We know that the transfer of evidence is tremendously important and that it needs to be an active dissemination. So the only way that you can have this transfer is to get this out into articles or into different posters or talk about it, whatever you're going to do actively to disseminate these results, and to integrate it as well into systems and back it up with educational programming if that's appropriate. The implementation of the evidence is tremendously important, and these implementation projects are predominantly what you're going to be doing in your DMP projects. Very important is to do a content analysis and then to really plan this evidence-based practice and take this information to the patient's bedside. Again, very quickly, when we look at Joanna Briggs, I did a clinical fellows program, which I like to think of it as a mini DMP. It really informed a lot about this translation of evidence and using this evidence-based practice kind of approach. For me, this implementation project was a real learning experience. I had a sabbatical over the fall semester and utilized that time to do this. It took me through every single one of the individual steps and really the importance of each of those steps. So I learned a tremendous amount. Joanna Briggs, like any of these other models, has materials and tools that it utilizes. There is a Joanna Briggs approach to implementation, for example. So it really is just an example that I wanted to utilize to help us out with these different models. So as we move forward, the first model that we're going to talk about is the Stettler model. Stettler model is one of the older models that has undergone revision and revision and revision. The STET model, originally talked about this implementation of evidence, and it had moved forward from research utilization, which is what RU stands for, that research utilization, just essentially taking that evidence to the patient's bedside, and we know that EBP is much bigger than that now. So what I've done with each of these individual models is gone through and tried to summarize for you. It is really important that you read these individual descriptions that are in Melnick and look for really those things that resonate with you, those pieces of these models that is something that you could utilize in your approach moving forward. Again, knowing that you're going to have to pick a model and base your DMP project on that. So when we look at the Stettler model, it really puts the advanced practice nurse or that educated individual in the driver's seat for this whole evidence-based practice kind of a change. So it takes that individual that has those skills that are required in order to be able to do this and really puts them on the forefront. When you look at the individual components of the Stettler model, there is discussion about preparation and validation. Again, knowing that the components of this model are important when we look at individual pieces that are utilized. I'm looking for it. Here we go. So making sure that the priority or need of this project is important. It plays into that validation as well. We know that validation also is the ability to go to the literature and make sure that the evidence is present. We look also at the ability to translate that to the clinical setting, um, and to utilize the application of that and decision-making types of approaches. And then we know that that translation is kind of at the end of this, where you're taking that to the clinical site, and the important piece to that as well is evaluation. And these are all described in your individual textbook chapters, or not chapters, excuse me, the individual descriptions of the model. So there are assumptions that are utilized in that. The individual assumptions I have starred here. The first is that there's an assumption and almost a definition of what it means to be a leader and what the roles are to lead this change. Again, it requires all of these skills to be present, and then to have those individual pieces there. It talks about the individual P's. So when we're talking about P's, we're talking about policies and procedures. We're talking about protocols and programs, as well as performance. And to consider all of those individual P's, if you will, is very important. And it really provides the Stettler model with kind of the foundation to then move forward. As you're pulling all of those individual pieces together, it's important, again, kind of as an assumption that that evidence is going to be utilized. Critical thinking is tremendously important. Again, the Stettler model really based itself in critical thinking and the ability of that advanced practice individual to inform other individuals and really help them to think through the problem. Validation in evidence use is again important, and when we talk about that, we're talking about the use of essentially that very high level evidence, the utilization of clinical practice guidelines. That's what CPG is. And that level 1 of evidence is tremendously important. Also, the practice change is important. That's really the central focus, and Stettler provides a nice, or Melnick provides a nice overview of these individual pieces. Interventions also, and the ability to conceptualize this information is important. So these are all the individual pieces of this Stettler model. Again, it is an older model and tends to have a tremendous amount of support. It's in the literature quite a bit because it's been utilized for quite some time. As we move forward, I'm sorry, I bumped two. No, I didn't. Okay, there is a second model called the Iowa model, and Iowa is also something that has been around for a while. Iowa has, as with Stettler, quite a bit of support for use. This Iowa model is based on Rogers' diffusion of innovation theory. So the ability to be able to have an innovation that is able to diffuse through practice and get to the patient is tremendously important. For me, this Iowa model really looks like an algorithm. My context is as a critical care nurse working in the PACU. I think about ACLS all the time. And for me, this approach, when we look at Iowa, has multiple questions and then feedback loops that kind of pay back into this. So for me, it's pretty concrete. It really step walks you through the EBP process. And I think there are some individuals that think that that's a really good thing. There were several students that used the Iowa model in the last group that just graduated. So this is something that's relatively popular. When you look at the Iowa model, there are individual steps that have been teased out, and these steps are broken down and described beautifully by Melnick. It begins with whatever that trigger is. So maybe this project is, the trigger was a change in patient outcomes. Maybe unfortunately, an infection rate went up that really generated this, or there was a finding from a performance improvement piece. So that trigger is something that's identified as a need, and it really starts the whole algorithm. The practice question is developed, and we've talked about the practice question, and according to this flow, this algorithm, if you will, that practice question is what really helps you to make the next decision. So you move into then number 3, and that's the question and the purpose is developed if you're moving forward. Number 4 deals with the priority and the identification of team members. I would say stakeholders and team members. And when we're talking about priority, that's engaging that stakeholder that is going to, from the organization, that's really going to say, yes, this is absolutely a priority that we have. 5th step is that access to evidence. And when we look at access to evidence, we know that there are pieces to it. I put this just as an abbreviation because we're talking about assessing, appraising, synthesizing, and I'm missing the last S. So you'll have to find it in your reading. I can't pick it out right quickly. I'm sorry. So these are just steps that are utilized as you approach the evidence. We know that step number 6 is to design the study itself and to pilot that change. So a pilot really is a dry run. It gives you the opportunity to kind of look at the protocol that you've established and to try it out on a few of people that meet your sample that you've selected, and it really allows you to refine. This was something that I learned in my clinical fellowship program, because we had a protocol and luckily for us, we didn't really do a trial run, but we met with the stakeholders, and we hadn't actually begun the change itself, but we did baseline data collection, and that baseline data collection really informed our practice. So it wasn't really a pilot of the project itself, but it enabled us to see that there was a real educational need that we were able to then prevent, if you will, a barrier to change moving forward. So the decision is really that piece that deals with that pilot that I talked about. The integration is here, and when we talk about that shouldn't be decision, that should be design, and I apologize, that's typo from mine. The design piece is with the pilot, and the decision is then to move forward. Integration is really important, and that is to be able to integrate it into kind of the status quo. If you have a change that perhaps the people that you work with don't really like, and they refuse, they're going to do it because it's something that they have to do, but they don't actually integrate it into daily practice and continue with it along the long road, then it's not going to be a change that's sustainable. Iowa also talks about the importance of dissemination. And what I did with this is there are more steps described in the Iowa description, but I actually combined several of these in order to get it to fit on the slide. So, for example, priority and team would be separate pieces. If you move forward, and we'll go to the next model, that model is based on the Iowa framework. This one is entitled the Module for Evidence-Based Practice Change. Again, this came out of the Iowa model, but it is an attempt to simplify this. It is based on also performance improvement and the ability to maintain that change over time, that sustainable time. So, excuse me, let's say that the Iowa model perhaps was a little too complex for you. It might be that this model would be something that you would find easier to utilize. Again, this model has 6 different parts to it, and this is starting to get redundant. Again, the need of change, to be able to locate that best evidence and analyze that evidence, and then to decide to design the practice change, to implement it, to evaluate it, and then put into place these plans for sustainability. So this is based on the Iowa, and it has many of the characteristics of the Iowa, but it's not as perhaps complex as Iowa would be. If we're continuing forward, there's something called the ARC, Advancing Research and Clinical Practice Through Close Collaboration, and that is the ARC method. And this is based in cognitive behavior therapy. So this one has a global approach as well. When we talk about cognitive behavioral therapy, or excuse me, theory, this just deals with our ability to kind of plan things out and change behaviors. It puts this individual and organization together in this type of sustainable change. So really both of these pieces are integral to it being successful. This ARC method is very based on this sustainable change, and talks about cultivating the entire system culture around these evidence-based practice activities. There are 7 control theories or barriers, if you will, to change, and they're identified quite well for you, I think, in this individual presentation in the Melnick's chapter. Again, I'm not going to go through them individually, but it provides you kind of different things to pre-think and to plan that could be barriers to change. So this module, the components are organizational readiness. So this starts on the organization itself. It's the ability of the organization really to embrace the need for the change and to provide that environment where the organization is on board and really assisting with this. It also provides mentors, and these EBP mentors are tremendously important when you look at their contribution. So EBP, when we look at the ability to have mentors, that is the ability for this individual to have someone that you can go to and actually have feedback, receive feedback. I do think that there was a student that used this method and actually took this schematic and added in her individual strategies into the schematic, and you can see how essentially one piece interplays with others. EBP belief scale is a scale that is part of this ARC approach, and it is used to determine the readiness, if you will, and the value for EBP in this organization. So It is an instrument that has 16 Likert type questions, and it's designed to be used to really find out if we're ready to do this change. And then obviously there's a big piece with you would implement and then make sure that that evaluation piece is there. Evaluate the evidence and then also evaluate the change that is in place. So another type of an approach, very different wording. As you read this in your chapter, I encourage you to see how it fits, if you will, with evidence-based practice and could contribute to this type of change. I think it's very, very different. There's the Paris approach as well, and Paris stands for Promoting Action on Research Implementation in Health Services Framework, and that's what that individual Paris stands for. Here you're looking at the interpretation of multiple factors that would contribute to this process. When we look at the overview, it's really important to look at the complexity and how the complexity can influence this EBP project. So we're really trying to break this down into individual components and that complexity piece. And by doing that, to be able to really, wrap your arms around. This uses something called a concept map approach. And if you've ever used a concept map, what you're doing is really identifying the linkages in the individual pieces of this complex project and identify kind of how they're linked and how they can influence each other. Important is the work of the individual in the concept map, the work of the team, and the role of organization in the global approach to this whole project in order to have successful implementation. And that's what that SI stands for. This approach also kinds of grades these individual pieces as high, medium, and low. And the goal of this Paris is to have the implementation, all of these components, these approaches, if you will, all three of these parts of this greater complexity to be at that high level of evaluation, if you will, to be measured at that high level, so that the organization is, all three of these pieces are ready to go. And if you have that high level for all three, then it is assumed that you're going to have a better ability to have that change take place. So these are all kinds of individual parts to this actual model. And when we look at the way the model then moves forward, so you've done this big assessment of all these parts, and there's readiness, a high level of readiness from the organizational piece, from the team piece, as well as from the individuals in the organization. So you've got that high level, then you'll use the individual components. Again, those components are the evidence itself. Obviously, you're going to look at that evidence, appraise that evidence, and make sure that that evidence is solid. We're talking about evidence, both local evidence, like performance improvement evidence, as well as that evidence in the literature. You're going to look at the context. The context becomes very, very important because this is the environment for change. And I thought that that was interesting when that came in. I think the context also is tremendously important. There's a typo here, and I apologize. It should be facilitation. It's the ability to actually facilitate that implementation of the project. Um, so those three pieces work together into the actual implementation itself. So the ability to facilitate, considering the context, and also looking at the evidence are all three parts that are tremendously important. And then the implementation looks at each of those components on a continuum. And again, it's that high piece provides that readiness for the change, and it can increase research utilization. So a very, very different kind of approach. In this approach, you're assessing these individual components, and then it's used to really identify and move forward then with the evidence-based practice approach. When we look at the clinical scholars approach, clinical scholars are, again, very, very different approach. Clinical scholars are based again in that diffusion theory and the ability to create a change and have it diffuse more globally. But in this, there is a focus on the development of individual staff to be that expert, that individual that's able to really drive this whole process. So it's that scholars program, and there are goals that are actually in place that inform what's needed in a scholar. And then the expectation is that if you create and mentor and educate that individual to be an actual scholar, they're going to be able to really foster and facilitate that evidence-based practice program much better. So that scholar is able to challenge practice and ask those hard questions, and to prepare providers, so individual staff members perhaps, or whoever's involved in this change, really empower them to be able to be part of this change. This scholar is able to complete the critical appraisal that needs to happen of the evidence, and to identify the individual research, and to develop then the project that's going to be utilized by those clinical scholars. So things that are desired, if you will, in an individual to be in this educational opportunity, to be this scholar that's going to be identified, is that person that's able to be a really good observer, and to be able to look at that, use that observation to reflect. So that's the person that's able to really identify those individual components, again, to ask those hard questions, and then be able to step back and really think about them, and critically think about how they're going to impact. Obviously, this individual needs the skills of being able to analyze and critique evidence, as well as be able to synthesize that evidence, to be able to pull it all together and translate it or apply it to the individual clinical setting. That individual should be able to complete the evaluation at the end of this, and then to be able to disseminate. So the textbook talks about strategies to develop this this scholar, this person that's able to really drive these protocols moving forward. Is that individual that it has attended these 6 to 8 workshops. So there's an educational part to this. That education, I apologize, this individual has equal parts education and the ability to process, if you will. So that person is schooled, if you will, and schooled in in both kind of the important things, the analysis and critique, the synthesis and the application piece, but also schooled in the ability to critically approach this type of change that we're asking for. This person's able to identify infrastructure that's needed, that's required for the change to happen, and that to provide that support for innovation. The American Nurses Association has a lot of information on the importance of nurses being able to innovate. And then that evidence-based appraisal that can be used. So these are the skills that are all developed by these clinical scholars. We know that these clinical scholars, and when you read this in your textbook, they're found in a variety of settings. If you look at this online, this is a pretty popular approach that's used in a interdisciplinary application, which I think is kind of cool. The next one is the Johns Hopkins approach. And Hopkins came out of really a call from staff nurses to have this ability to do evidence-based practice. So to really put the onus on the nurse at the bedside to be able to do this. These nurses at Johns Hopkins identified that they wanted to be able to have these skills, but they wanted it to happen through a more of a linear approach, something that individual tools could be developed so that they could be utilized. And I apologize, this slide was goofed up when I saved it, and these things are not lined up appropriately. When we think about the approach, there's something called PET with this Johns Hopkins approach, this model. And it utilizes this PET, this ability to, I'm looking for it because I did not write it down and I apologize, utilizes this process, practice, question, and evidence is what PET stands for. Again, the practice, question, evidence, and translation is this PET, this PET. And it utilizes this PET to develop questions and then to change practice. And it really, what the nursing staff wanted was this kind of flow that literally takes you from step to step to step that you can identify. They worked very closely with the School of Nursing at Johns Hopkins and came up with literally these individual parts that can step walk staff nurses and provide the support that's needed, that they're able to put these EBP projects really into place. So it is a highly successful module because, again, it really step walks you through each of these individual parts. This Johns Hopkins developed actually 10 different tools that are part of this. Again, there's a tool for this PET process that I talked about. There's a tool that is utilized to assist with the development of the PICO question. There's a tool literally that is used to assist with the identification of stakeholders. A tool for finding evidence. This is one that they recommend working closely with research librarians. When we talk about that evidence, that ability to research evidence and to identify the evidence, both found in the research itself, that empirical evidence, as well as non-research areas, because we know that not all questions that nurses ask are going to have those systematic reviews, and you may find that it's expert opinion or it's case-based or whatever. And it's this fifth tool provides that ability to appraise both of these types, the fifth and sixth types of evidence. The seventh is the ability to create an evidence summary, and that evidence summary is perhaps a table format. That tool would help the individual begin that synthesis piece. So a tool to actually pull that evidence together, and then a tool to assist with the synthesis. And then based on that evidence to develop an action plan, it's a tool to utilize to really make that whole evidence-based practice approach. There's a tool for dissemination that's very important. I'm going to back up to that action plan. Remember, that's really moving forward with the entire project, and to do it through individual steps that are found in that action plan. And then the final piece is the dissemination. It also provides the ability to rate the evidence for both strength and quality. So that was something that was talked about by Melnick as another really big plus, that in addition to perhaps leveling the evidence, they're really looking at the evidence as well for strength and for quality. And you can see in this illustration that's used, again, used by DMP students in their projects. I saw this used several times. They actually added in their individual parts for each of these pieces moving forward. So an interesting tool. We're almost done. You're doing beautifully. We're 51 minutes into this. And we're going to talk about this Stephen Starr model. Which it is a model of transformation that is this ACE, if you will, developed by the University of Texas. Of course, there's the star, if you will, from Texas. And it came out of an academic center for evidence-based practice that's called the ARC. This ARC came together to try to make this an easier approach to evidence-based practice. Again, that would really step-walk individuals through this process, and to identify the important pieces. There are 5 points on the star, which really shows you that cyclic approach to evidence-based practice, where you literally are going 1 through 5 and then starting back at 1 again. The premise is for knowledge translation, so we're back to that knowledge translation piece again. And there are approaches that are used in each of those individual pieces. So the first is that knowledge translation is needed for decisions that are made. So that is a premise. These are kind of almost like assumptions. A second premise is that there's a variety of forms of knowledge. So we know that there is research knowledge, but we also know that there is the knowledge that is perhaps from a clinical perspective. We know that most stable knowledge is research. So that, and I won't say solid, but the most perhaps irrefutable knowledge is found in research, but that there's knowledge in many, many different places. So these two kind of pull together, if you will. The fourth is this evidence hierarchy. So we know that the premise is that evidence is found in a hierarchy, and we really take that one to heart. That's something that we talk about a lot. We know that knowledge exists, again, in many forms. So it doesn't all have to be research knowledge, that it can be found in a variety of different ways. and that knowledge can be packaged, quote unquote. And when we talk about packaging knowledge, that's the ability to maybe put it into a protocol or an EBP project or whatever the outcome pieces are. So that knowledge can be parceled, if you will, and utilized in different ways. Knowledge also is determines usability. So it's a form of a determinant of usability. So that knowledge can be utilized to kind of describe what can and cannot be. Again, knowledge can be transformed, we know, into a variety of different ways. So knowledge can perhaps inform practice change. Knowledge can change our approaches if it's a new approach. So perhaps a better use of that drug or a better approach to dealing with stress ulcers or something to that effect. So a very, very different approach when we look at this. This is all based in knowledge. Again, similar to the Johns Hopkins, because it kind of step walks individuals through this. I did see actually one DMP presentation that utilized this approach. So just to summarize this entire chapter, you will be using a model of evidence-based practice, one of these approaches to generating evidence. When you look at the way you're going to do that, you're going to use one of these. It is actually required in your presentation, in your approach. And you'll find that when you pick this individual approach, it provides organization and informs the way you're going to move forward. That structure is tremendously important, and it's needed for the entire project. Again, this is just a quick and dirty overview where I've pulled out individual parts of this. Please know that I'm going to correct my typographical errors and the errors in the slides that appeared because this had to be shrunk in order to make this recording. So that'll be fixed in your PowerPoint that you can utilize then as for reference or to take notes. And I encourage you to think about these different EBP modules or models, excuse me, and as you move forward to really consider the one that speaks to your PICO question and your project moving forward. So I know this is a pew, literally a phew. This has been a lot of information really quick. We're going to talk about this as we get into our workshop and as you move forward. This is not an expectation for this semester. This is just an introduction to this information, and you'll be working on this as you further define your project and continue moving forward.